Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamigam. Proliferative lupus nephritis is both an organ-threatening and a life-threatening complication of systemic lupus erythematosus. While immunosuppressive therapy has improved in the past 20 years, there remains a significant risk for lupus nephritis patients of progressing to end-stage renal disease. The manuscript we will discuss today is Kidney Outcomes and Preservation of Kidney Function with Obinutuzumab in Patients with Lupus Nephritis, a post-hoc analysis of the Nobility trial. It was published in Arthritis and Rheumatology, and the data was presented at the 2023 ACR Convergence meeting. A link to the manuscript and disclosures are in our show notes from today. I'm happy to be joined by the manuscript's senior author, Dr. Brad Rovin. Dr. Rovin is the Hebert Professor of Medicine at The Ohio State University Wexner Medical Center. Dr. Rovin received his Bachelor of Science in Chemical Engineering at Northwestern University and his Doctor of Medicine from the University of Illinois Medical School in Chicago. He then completed a residency and fellowship at Washington University in St. Louis, and he is now the medical director of the Ohio State University Clinical Research Management Institute. He's served in multiple leadership roles for the American Society of Nephrology, and he is also the founding member of NephroNet, a grassroots nephrology community clinical trial organization, as well as serving as a member of the Lupus Clinical Trials Network. Welcome to the show, Brad.
Thanks so much for having me. It's a pleasure to be here.
So, Brad, you've spent much of your career studying glomerulonephritis, particularly helping put together clinical trials in glomerulonephritis. And the data you present here is data from the phase 2 Nobility trial. Would you mind giving us some background on the Nobility trial?
So we completed the Nobility trial a couple of years ago, and what we were looking at was obinutuzumab, which is a B-cell targeting agent. So it's an anti-CD20 antibody, much like rituximab, but different in many important ways that we can go into in a bit. We added obinutuzumab or placebo to standard of care therapy, and at the time we did this, we used mycophenolate mofetil, or MMF as I'll call it, and glucocorticoids. And then we followed patients prospectively to understand if there were more complete renal responses in the obinutuzumab group. What was unique about the trial at the time we did it was that only one other trial was conducted for the length of time as this trial, which was 2 years, which really gave us a lot of opportunities to study the effects of a novel agent like obinutuzumab on clinical parameters regarding the kidney that we don't often get a chance to look at, like progression of chronic kidney disease or lupus nephritis flare rate.
And tell us a bit more about obinutuzumab. You mentioned it's an anti-CD20 antibody, but it's a little bit different from other agents that are already available. Tell us why.
I think most of the audience is going to be very familiar with rituximab, which is also an anti-CD20 monoclonal antibody. Rituximab is not completely humanized. Obinutuzumab is a completely humanized molecule, and it's also called a type 2 anti-CD20 monoclonal antibody. And it's called that in reference to type 1, which is rituximab, because it has enhanced B-cell depleting ability compared to the type 1 anti-CD20 antibodies. This is done by changing the manipulation, or actually it's called glycoengineering, of the antibody. The molecule has some differences in the FC region of the antibody, and this actually increases antibody-dependent cytotoxicity about 100-fold. In addition, it changes the binding conformation of this monoclonal antibody, and that causes greater degree of direct cell death. It also reduces the internalization of the antibody, which allows it to be more effective. And something that's really important for patients with lupus and lupus nephritis is that it relies less on complement mediated cytotoxicity than other anti CD20 antibodies. Why is this important in lupus? Well, as everyone listening almost certainly knows, complement is consumed in active lupus and especially active lupus nephritis. And so, if your mechanism is highly dependent on complement being available for killing the target cell, i.e., the B cell, then in complement consuming states, your antibody may be less effective. So these are pretty significant differences. And of course, the molecule was developed for treatment of malignancies, B cell malignancies, and we've sort of brought it over into the autoimmunity realm.
Totally makes sense. And so, what was the dosing schedule used in this study, and what data were used to inform that dosing schedule?
So the obinutuzumab, the Nobility study, utilized the same dosing regimen as what we use for rituximab these days. And I'm not sure if I can say that data from the malignancy field has helped with the dosing regimen, or that this was based on what we saw with the regimen of rituximab that we currently like to use. In any case, we use obinutuzumab 1,000 milligrams at the beginning of treatment, and then 1,000 milligrams 2 weeks later. And then this 2 week dosing interval is repeated at month 6, and then no other obinutuzumab is given.
And who enrolled in your study? What were the demographics? And then specifically, which classes of lupus nephritis did you include? Was it just pure class 3 and 4? Did you have patients who had concomitant class 5?
So, for this particular study, again, it was a little bit different than most preceding lupus nephritis trials, and we restricted this to patients who had proliferative lupus nephritis, so class 3 or 4, and they could have a membranous component, so it could be 3 plus 5 or 4 plus 5, but we did not enroll pure class 5 patients. And that was by design. The idea is that class 5 has, as a disease entity, certainly has a different histologic appearance and is much less inflammatory than the proliferative classes of lupus, but also responds to similar therapies, but the sort of tempo or kinetics of response is different and longer. And so sometimes I believe that by including class 5 patients, you actually detract from how the drug is actually working with class 3 and 4. That's not to say that studying class 5 is not important. It certainly is, but I think it should be studied in its own trial. In terms of demographics, pretty typical of a lupus population for our patients. They were mostly young women, and we actually had a very good enrollment from Latin America and the Caribbean, Europe, and the United States. So we had a fairly high representation of patients with Hispanic ethnicity. And we had patients who were then a mix of patients who were white, Black, or African American and Asian. Unfortunately, like most current lupus nephritis trials, our goal was to have more people of African American ancestry, and we did enroll in each arm about 10%. But the goal realistically should be much higher as they have disproportionately severe lupus nephritis.
I think that's probably a whole podcast on its own, the challenges of recruitment to clinical trials. But tell us now a little bit about the differences between this analysis and the results that you'd already presented from the Nobility trial. So you've previously presented and published data showing improvement of renal responses compared to the standard of care arm at the 104 weeks from this study. Tell us what this current analysis was designed to evaluate.
So, because the Nobility study was conducted over 2 year period of time, we were able to really see they're not long-term effects of how the kidney responded, but they're certainly longer than the usual 6 months or 12 months that many trials in the past had lasted. So, what we were specifically looking for in this study with respect to kidney function was how did the patients do who were treated with placebo versus obinutuzumab relative to decline in kidney function over time. So, starting with the premise that once you have lupus nephritis, even if you treat it well and it resolves, you're generally left with some chronic kidney damage. And over time, we can see the GFR or glomerular filtration rate, which is a measure of kidney function, decline. We want that decline to be as absolutely slow as possible so that a patient maintains kidney function for their entire life expectancy. And so, what we did with this study was to look at the GFR that we had taken at many different data points in each arm of the study, and then plot a slope of decline of kidney function. So that was one of the things we were looking for in this particular study. In addition to that, because of the duration of the study, we looked and were able to look at flare response. So, in other words, once a person gets a remission, then we want them to maintain that remission and preferably maintain remission forever, because every time you have a flare of lupus nephritis, so active disease comes back, you are causing inflammation in the kidney, and that contributes to damage and then eventually chronic damage. And the more flares you have, the more risk you have of actually developing progressive chronic kidney disease, which ultimately can end in kidney failure requiring transplant or dialysis. So that was sort of the big things we were looking at in this post hoc analysis. So, in other words, the data is already there. These weren't part of the original trial, but they provide more insight into what the drug can do. And the other thing we looked at was whether or not we could get away with using less glucocorticoid, something that's an important goal for all of us who treat patients with lupus.
So, walk us through the graphs first. You looked at time to kidney related events, so time to lupus nephritis flare, time to reduction in eGFR by 30% and by 40%. Tell us what you found.
So we looked at 3 or 4 different things. The first thing is this slope of GFR. So GFR conventionally is measured in mils per minute per 1.73 meters squared of body surface area. This is just how nephrologists have always measured GFR, and that's the blood volume that's cleared or filtered by the kidney. And so, again, the slope that we're looking at is a measure of decline of kidney function over time. And what we found then was that in the patients who were given the obinutuzumab, this slope was actually lower than the patients in the placebo group. And it was the annual difference in the slope was about 4 mils per minute per 1.73 meters squared. What that means in regular language is that over the 2-year trial, the patients who did receive the placebo, so not obinutuzumab, lost 4 mils of renal clearance. And you can say, well, that's not very much, but it really is very important, because the decline in kidney function, if you then took that and plotted it out, if that was to continue, your ability to maintain kidney function for your life expectancy would be greatly diminished.
Every
And
glomerulus counts, right?
well, I like to say time is nephrons and all the nephrons count. So this was a key finding. And we know that if we can preserve kidney function by 1 mil per minute per 1.73 meters squared per year, that you actually significantly lengthen the survival of a kidney. So 4 mils is even better. Okay, so
Hmm.
that's to try to put that in perspective. The other thing we looked at was a decline in 30% or 40% of kidney function. So, in other words, you're starting out, let's say, at a kidney function of 100 mils per minute, and you decline by 40%. So now you're down to 60. Okay. And there were far fewer patients who hit that adverse outcome in the group that was treated with obinutuzumab. Now, there's a caveat here. This was statistically significant for the time to first decline of this magnitude in kidney function for 30% and 40%. We also looked at sustained decline. So, in other words, let's say you hit that mark and you never recovered from it, and that we didn't have enough sufficient data for statistical analysis, but it also trended in the same direction favoring obinutuzumab. Now, you can say, well, why do you care about a decline in kidney function of 30% or 40%, whether that be acute or chronic? Well, in the chronic setting, these are harbingers of future kidney failure requiring renal replacement therapy. When you think about a decline in kidney function acutely that maybe recovers to some extent of 30 or 40%, those are big decrements in kidney function. This is acute kidney injury. And acute kidney injury, we thought, well, when acute kidney injury gets better, the patients do fine. But what we found in the last many years is that patients who have acute kidney injury actually are predisposed to chronic progressive kidney failure. So these are both important endpoints for kidney survival. And then the other really important thing that we looked at was kidney flare rate. And the rate of lupus nephritis flares, the hazard ratio, if you will, was 0.43, and that was also statistically significant, favoring obinutuzumab, suggesting that we had a decline in flares of about 60%. So, very exciting data when you put this all together in the appropriate context. You say you're having, yes, the nobility study itself, the primary study was to show a benefit of obinutuzumab in achieving complete renal response at the end of 1 year and 2 years. But now you can say, well, okay, not only did obinutuzumab successfully reach that endpoint, but when we look at the totality of the data in terms of long term kidney survival, this is checking all the right boxes for keeping the kidneys healthy over the long term. And I think that's really what we want when we're talking about lupus nephritis therapeutics. It's fine to look at these short term endpoints at a year of improved renal response rate, but what we really want to see is that the kidney maintains survival over the patient's lifetime.
And really exciting news. What did you find with steroid use? I know there's always a desire to find agents that generally give a steroid sparing effect. Was that true here?
I think so. The way we looked at this is a little bit complicated. What we wanted to see was, did the patients have a complete renal response? So, this was the endpoint from the original Nobility study, and they were on less than 7.5 milligram per day of prednisone. Okay, so the idea was, can we sort of figure out if patients who were taking obinutuzumab had a higher complete renal response rate with this very much lower dose of prednisone than patients in the placebo group. We
Hmm.
saw that at week 76, which was about 3/4 of the way through the study, 38% of the patients receiving obinutuzumab were able to have the complete renal response with that level of prednisone, less than 7.5 milligram a day, compared to 16% in the placebo arm, so about double. The ratios were fairly similar at week 104, but at week 104, more people in the placebo group actually did eventually achieve a complete renal response. So it was 38% in the obinutuzumab arm versus 22% in the placebo arm. And that was just not quite statistically significant, but the trend was similar.
So perhaps at least steroid sparing and steroid sparing more quickly.
I think that this is really sort of something that now that we've started thinking about it, we can apply to the next trial, the ongoing trial, obinutuzumab, for understanding larger trial what we can do with steroids in this setting. And
Yeah.
as you said, it's really important for our patients because of the multitude of adverse events that are associated with glucocorticoids.
And I know this phase 2 study, the Nobility study, had kind of limited numbers of patients in the study. Can you tell us anything about lupus class and drug effect? Was some patients more responsive than others?
That's interesting. I have not seen a breakdown of the data by class. And I will say that obviously I'm a nephrologist and I love nephropathology. I find the distinction between class 3 and 4, yes, there's histologic differences, but I think of the disease as inflammatory.
Mhm.
So I'm not sure that we're going to be able to tease out a class difference. And I think truly what we really need to do is, and this would be going off on a big tangent, so I'm just going to stop at the end of my sentence, or you and I will both be in trouble for time. But I do think what we have to do is have an understanding of the underlying pathophysiology and molecular pathogenesis of the disease to truly classify lupus, because the kidney can only respond histologically with various patterns, but a lot of stuff that's different can be boiling around underneath to
Mhm.
create those patterns.
And then are you allowed to tell us anything about side effects? Were there any concerning signals in the obinutuzumab group?
Well, the side effect profile was actually published in the original paper from the Nobility trial. And it's always amazing to me. You're taking medication that is very potent at eliminating B cells, much more potent than rituximab, and adding it on to what at that time was starting with higher dose glucocorticoid and then mycophenolate, MMF. And what we saw as a side effect profile was pretty similar to the placebo group. So,
Mhm.
in other words, we didn't see a large number of more adverse events in the obinutuzumab arm. And deaths were very small in that trial and certainly not more in the obinutuzumab group. There was only one death versus four in the placebo group. Serious adverse events actually occurred more often in the placebo group. And then, of course, the thing we think about most is rates of infection, right? Because
Mhm.
these are very effective immunosuppressive drugs. Remarkably, serious infections occurred in only 5, so 8% of the obinutuzumab arm versus 11 or 18% of the placebo arm. So, really, remarkably no safety signal. And I'm always amazed at that. And maybe I shouldn't be, because as nephrologists, we combine multiple immunosuppressive therapies all the time in the kidney transplant world. And of course, transplants have done very well over time. So I'm very happy about that, because that's the other thing. If we create new therapeutic regimens, but they're so highly toxic patients can't tolerate them, we're not really benefiting the patient.
And I think we always have to remember that high dose steroids have significant infection risk, right? Which is probably the signal you're seeing in your placebo group.
That tends to overwhelm everything at the beginning. And I think
Mhm.
now that we're becoming much more sophisticated and realizing that we can use a lower dose of glucocorticoids, hopefully we're going to resolve side effects, but we may see the true effect profile of the newer drugs. Remains to be seen.
Which brings me to the next step for obinutuzumab, which is this phase 3 study called Regency, which I believe is currently ongoing.
Yes.
So I have to ask you, I come from England. We love our royal family, but nobility and regency, where do these names come from? Is this just clever marketing from the company trying to produce the king of B-cell inhibition?
Interestingly, I tried to understand if nobility was an acronym because so often we make acronyms that are very cute for clinical trials, as you probably know. Nobility was chosen, this is above my pay grade, of course, at the company because it had OB in the middle, right?
Ah.
So obinutuzumab. And then Regency was exactly sort of as you said on this theme of royalty. But I think that the names are the names. I sort of, in my head, I call it obinutuzumab phase 2 and the OB study phase 3, which, as you said, is ongoing. It's very exciting. It's enrolled completely now, and we're waiting for last patient, last follow up. And then the results will be obviously assessed and become available in the public domain. And we're hopeful that this will replicate the phase 2 data and show a significant benefit for the patients receiving obinutuzumab.
Well, we're all waiting with our breath held to see what you find. Exciting times for lupus nephritis.
I think so.
So I'm going to change tack now and ask you a little bit about lupus clinical trials, because this is an area that has historically been extremely challenging, as you know. And as a nephrologist, you come to this with a different perspective than the rheumatologists who are trying to fix the whole person. But here it seems like the kidney-focused approach really paid off. What lessons have you, as an individual collaborating with rheumatologists, learned over the years? And what lessons have you, as a nephrology community, learned over the years of studying lupus nephritis?
I think we've learned many, many things, too many to list now, but in brief, I think, and you're correct, I collaborate with rheumatology all the time, and my clinic is a specialized clinic with rheumatology, so we see patients together, which is very efficient. One of the things we learned from many trials is that when you have high dose glucocorticoid and high dose immunosuppression at the very beginning, it's really hard to see an effect of the drug.
Mm-hmm.
So we have been working hard to actually reduce glucocorticoid dosing and do so without harming the patient, of course, or harming the outcomes. And I think this has largely been successful. The second thing that I think we learned is that lupus nephritis takes a really long time to resolve. And so the expectation that the drugs would be effective and show a significant difference at 6 months, and if you remember, a lot of our
Mm-hmm.
trials at the beginning were 6 month duration, really was probably overstated. And even trials at 1 year were sort of really on the edge of what could be accomplished. I think now the community realizes the benefit of looking at a longer trial. And this is, of course, the Regency trial, the Nobility trial, and the Bliss LN trial were all 2 years. And many of the
Mm-hmm.
trials coming up are looking at 2 year timelines. So I think that's been quite effective. The third thing we've learned is that proteinuria is a fraught endpoint. We
Mm-hmm.
need to do better than proteinuria. That's part of what goes into a complete renal response. It's very important, of course, but proteinuria can mean a lot of things. It can mean active disease, but you also get proteinuria and chronic damage. And if your mechanism of action of your medication is inflammation and you no longer have inflammation, you're not going to fix the proteinuria, and you might actually call patients who have responded histologically non-responders.
Mm-hmm.
So that's something that we now realize in the field. We have to have good biomarkers, better biomarkers than what we currently have clinically to assess kidney function outside of histologic and repeat biopsies. So I think those are some really important things that I've learned over time. The other thing that I think is really important, and I think we've all seen this, is we have to match the mechanism of action of the drug with the end point and what we expect to see. And it's really unlikely that a single drug is going to be effective for everyone with lupus nephritis because the disease heterogeneity is so great. And I'm not simply speaking of the different classes of lupus nephritis, I'm also speaking of how that class originated. Is a person a high B cell person? Is a person a high complement person? Is a person a high interferon person? These sorts of things are going to become really important with these very precise targeted therapies. And so I think we're going to see these principles applied very nicely going forward. And at some point, I think we're probably going to try and enroll patients in clinical trials in which we know or have a good idea that the mechanism may be mechanism X, which your drug targets. And
Mhm.
that is really moving us toward this idea of precision medicine.
Which would be amazing and, gosh, would completely change the field. So now I have to ask you, your background is in engineering and you obviously like to solve complex mechanical challenges, but what attracted you to immune-mediated renal disease?
It's kind of a story. I loved engineering, and that was my undergraduate degree, as you said. And why I liked the kidney as an engineering marvel, right? Because it extracts waste products from the blood, keeps everything inside that we need, gets rid of the stuff we don't need. When I was much younger, I went into engineering with the idea that I was going to design eventually an artificial implantable kidney and solve the problem of dialysis. Okay, that
Yeah.
was my goal. And you can say, why? Did anyone in your family have kidney disease? Did it impress you? I have no idea why. I just liked it. Nobody in my family had kidney disease. And what happened was I'm old enough that biomedical engineering didn't exist. So I was a chemical engineer and I took biological courses. And I sort of started falling in love with immunology. And then
As
I
we
went,
all do. We feel you.
yeah. And, I went to medical school. Engineering is a really good prep for medical school because it teaches you how to think through problems. And I had my first immunology course my first year, and I loved it. And then I sort of worried. I said, gee, I want to do kidney disease and I also like immunology. Now, what can I do? I went to my advisor, who happened to be a nephrologist, and they said, study glomerular diseases. And of course, we knew very little back then, but that's sort of how it transpired. And then when I became a faculty member at Ohio State, another mentor said, because I was working in animal models, he said, why don't you help us with our lupus project in people? Because it's really important to treat people as opposed to rats. And I guess for anyone who's listening who might be sort of getting into the field or fellows, etc., sometimes the mentors make all the difference. And I've been very lucky to have excellent mentors at every stage of my career. But that's how basically it evolved. And it just sort of clicked with me when I started working in the field. My entire clinical practice, we switched over from general nephrology to glomerular diseases. We created one of the first glomerular disease clinics in the country, and it was a combined subspecialty clinic with my friends in rheumatology. So everything started making sense where what I was doing in my laboratory also, I had a vision for what it could do in the patients I'm treating. And it became very satisfying coming to work every day.
So it's almost like you didn't want to give up on the dialysis piece, but you realized that in reality, upstream of this problem is the immunology. And if you actually are successful fixing the immunology, you're going to put the dialysis guys out of
That
business.
That's I'm going to put my faculty out of business. Yes, that's exactly right. I figure if I can't solve this dialysis issue, then the best thing to do is to prevent patients from ever coming to dialysis.
It's a great way to think. I love it. And so, what tips do you have for people who are kind of on the growth edge of a specialty, where you are in that very diverse area of collaborating across multiple disciplines?
Well, I think all the folks that are coming up now have to realize that medicine has become and research endeavors have become very complex, and you cannot do everything yourself. And so, my advice is to be open to collaborations. Yes, you want your career to take off, but the way you'll do that is working with other folks who have similar interests. Listen to your mentors. Sometimes us old folks actually have some good ideas and can provide some good advice. And the other thing is to find a niche for yourself. What is it that makes you want to come to work every day and solve the problem? And once you have those questions in your mind, and I really tell my junior faculty, have 2 or 3 areas. Don't go crazy and have 50 areas because you'll not be able to work in them and you'll fail. But pick 2 or 3 things because at any given time, one project may be working and one may not. But I think if you have 2 or 3 things that are related but a little bit different, it really allows you to test the waters and sort of perfect yourself, invent yourself as an expert in some part of human disease. And you'll get great satisfaction from that, and the recognition will come later.
Yeah, great advice. So, now on a completely different note, I want to ask you about one of your hobbies. You're a fisherman, and your website states that you have a goal of fishing in every country in which you are invited to speak, which is in itself a noble goal. So, I need to ask you, have you already fished in every state? And then, second part of that question, which countries have you already fished in? And I have a global audience, so which countries are still on your list?
So I have not fished in all 50 states. I have fished in a lot of states, but my bucket goal is to fish in Alaska during the salmon run.
Oh, wow, that would be
Okay.
amazing.
Yes. And frankly, I just got back from a fishing trip in Florida with a bunch of other nephrologists. So fly fishing and nephrology sort of seems to go together. I don't know why. And I have fished around the world. One of my favorite trips was in Iceland. They have a very pristine fly fishing venues, and it's so pristine that you're told not to bring your own equipment. If you bring your own equipment, they have to irradiate it so that
Oh
you're
my
not
gosh.
contaminating their water. I collaborate with nephrologists and rheumatologists in Argentina, and I have been fishing in the mountains between Argentina and Chile, and that was quite an experience at high altitude, fishing for trout, and then having a barbecue at lunchtime. It doesn't get any better than that.
That is
And
literally you eat what you
well,
catch.
actually, and so I practice catch and release. I release most of the fish. Now, I did keep some occasionally, and there's nothing better than fresh fish. But so yeah, I have a lot of other countries left to visit, and I to fish in all of them at some point. But it's been sort of a fun goal. And my daughter gave me a map of the world where you scratch off and colors in places you've been. And so I can sort of now target areas that
So
I
you're
haven't
able to
been in.
keep track. Well, okay, so I'll crowdsource it to the audience of ACR Journals on Air. Dr. Robin is looking for speaking invitations. So, Brad, thank you for joining us today to discuss your data and share all your perspectives. It's been a real pleasure having you on the show, and I hope that our call out for invitations is successful.
Well, it's been a real pleasure to be here, and I'm glad I could do this with you all. And I appreciate my friends in the rheumatology community putting up with me.
Well, my thanks today go to our nephrology colleagues. In today's world, the phrase bean counters in medicine typically refers to an administrator who evaluates our RVU metrics. But nephrologists have always taken a different approach by looking after the beans that really count. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media, email us at podcast@rheumatology.org, and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.